Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Aquablation, a transformative BPH treatment, presented by Dr. Mark Saleh, urologist with Washington Township Medical Foundation. Dr. Saleh completed his undergraduate pre-medical education at the University of Western Ontario in London, Ontario, Canada. He earned his Doctor of Medicine degree with honors at the University of Toronto in Ontario, Canada. He then performed postgraduate training in urology at the University of Ottawa in Ontario, Canada. Dr. Saleh is board certified by the American Board of Urology. He is also certified in urology as a fellow of the Royal College of Surgeons of Canada. Please welcome Dr. Saleh.
Hi everyone. Obviously I'm Mark Saleh. I'm a urologist and I've been practicing for almost 25 years now. Lots of interests, especially BPH. I've been treating this for my whole career, obviously, and I'm excited to tell you about the newest technology that we'll discuss in detail later. It's called Aquablation. So let's start off, first of all, describing what the prostate is. It is a walnut-sized gland, at least it's walnut-sized when you're younger in life. It's at the base of the male bladder. Surrounding the base of the urethra as it exits the bladder. The main function of it is to help with fertility. It produces fluid that nourishes the sperm, it helps liquefy the semen so that the sperm can swim better, helps carry it along with the ejaculate. It normally grows to its normal adult size of about 20 grams, which is about walnut-sized, when a man is in his late teens or early 20s. The problem with it is it continues to grow throughout a man's life, and sometimes it gets, many times actually, it gets to a size that can cause issues because of obstruction. It is composed of glands that produce the fluid, but also has what we call involuntary smooth muscle that surrounds the urethra and can add to the symptoms by causing a tight tone that constricts the urethra even further than the obstructing glands. So what is BPH? BPH stands for Benign Prostatic Hyperplasia, which just simply means an increase in the number of cells in the prostate, in the glands and in the smooth muscle that causes a physical enlargement of the size of the gland. This is stimulated by the male hormone testosterone. So the two risk factors for having BPH is being a male and getting older. So there's no way around it. The rate of growth of the prostate is genetically determined, so some men are lucky enough not to have symptoms until later on in life, and some men, even in their 40s, can have severe obstructive symptoms from the prostate, and they could blame their dad for that. It's often confused with prostate cancer. BPH is not prostate cancer. It does not cause it. It's not related to it, and neither is the size of the prostate. You can have cancer with a small prostate. You can have cancer with a large prostate, and most people that have obstructive or irritative urinary symptoms is often related to benign enlargement, not from cancer. As you can see here, the BPH is extremely common. It can begin in the 40s. By age 60, half of men have an enlarged prostate, and eventually, if you live long enough, more than 80% of men are going to have an enlarged prostate causing them symptoms. About 30% of those men will require some sort of treatment. That's probably the surgical treatment. Probably more than that actually will require medical treatment or some other form of intervention. So what are the symptoms? There are two broad categories of symptoms that can be caused by the prostate. One are the obstructive symptoms, from physical blockage of the flow of the urethra, narrowing of the lumen, the size of the urethra. And the other category are the irritative symptoms that can result from irritation of the prostate, or the bladder rather, from the obstruction. The bladder has to work harder, makes it more irritable. The obstructive symptoms include things like a weak stream, difficulty emptying the bladder, difficulty starting or hesitancy, having to stand in front of the toilet or the urinal for long periods of time, intermittency, stop and go of the flow of the urine, dribbling at the end, post-void dribbling, feeling like you're not emptying completely, the need for double voiding, having to run back to the bathroom to empty that last bit of urine that is still irritating you. The irritative symptoms include things like frequency of urination, urgency, you got to run to the bathroom. If it's bad enough, you get something called urge incontinence, or leakage before you can unzip fast enough to get to that toilet. It can mean nocturia, or getting up at night multiple times, disturbing your sleep. And dysuria, or discomfort, pain even with urination sometimes because of that irritation and obstruction. Most people will experience those symptoms to some degree or other. In the other end of the spectrum, the more severe cases, you can get complications from BPH. That obstruction can lead to what's called a post-void residual, urine that you retain in the bladder. That can continue to increase to the degree where you have complete urinary retention, where the bladder is full, you have the urge to pee, you just can't go. And in those cases, you will require a Foley catheter, that tube that goes into the bladder to empty it into a bag. The residual urine can harbor bacteria that can lead to recurrent urinary tract infections. That residual urine also can lead to precipitation of crystals and sediment in the urine that can lead to stones, and that can be quite large. The largest one I ever removed filled the whole bladder and had to be surgically removed by an open surgery. And again, if the bladder is left in retention for long periods of time, which can happen silently, that gradual increase in the volume of the urine can get to the point where the bladder muscle becomes so hypotonic or atonic that it doesn't function. It's just a storage vessel that can't empty. And that is very difficult to treat if it gets to that point. And then again, at the very, very extreme end is what's called hydronephrosis. And you could see where the thickening of the bladder wall, the increased pressure inside the bladder volume can lead to the urine backing up into these ureters, the tubes that drain the kidneys, all the way up to the kidney, causing what's called hydronephrosis, or a dilated renal pelvis. And obviously the danger from that is that the kidneys can stop filtering. They just can't filter against that high pressure, and that can lead to kidney failure. So what does a urologist do if you end up getting referred or you visit a urologist for BPH? The first thing that you'll do is probably fill out a questionnaire in the waiting room or before your visit, called the AUA symptom score is one form of it. You could see it here. And it just basically is a quantitative way, a number that we can give the severity of your symptoms. It's a good way to get an idea how bad your symptoms are, and to track them later once we give you some form of treatment to see if there is a response. The doctor will do a digital rectal exam to check the size of the prostate and any signs of prostate cancer, like a hard lump or irregular surface. He will do a blood test to do called a PSA, or prostate-specific antigen. That's a protein made by the prostate. It's a normal protein. But the higher the number, the more likely that something is wrong with the prostate, whether that's an enlargement, infection, or prostate cancer. A creatinine level is done to check your kidney function. A urinalysis, or urine test, to check for protein in blood or signs of infection. And then, if intervention is considered, then the doctor may do a transrectal ultrasound to check the volume and anatomy, and a cystoscopy to see what the prostate looks like on the inside. In this image here, this is the image I would see through a scope that I would place through the urethra. Here, this is an enlarged prostate. This is the right side. This is the left side. And you could see that the urethra is this tiny little bit of black here, that little crack that the urine has to pass through, and the bladder is trying to push the urine through. This is the ultrasound image I would get. The ultrasound probe is in the rectum here. The ultrasound waves go up towards the prostate. This is the outline of the prostate. And we can get different views and actual measurements of the volume based on that. All right, so you have an enlarged prostate and you have symptoms that are bothering you. Those are the reasons to get treatment. The first line of treatment often is medications. And there are two categories of that, the alpha blockers and the 5-alpha reductase inhibitors. Alpha blockers work on the receptors in the smooth muscle in the urethra and prostate that cause the tone and tightness in the urethra. They relax that smooth muscle and functionally increase the volume of, or the lumen or the size, so that the flow can improve. They work pretty fast. If they're going to work, you should notice a result within a few days. Because they have that same effect on blood vessels, though, they can have side effects like a decrease in your blood pressure, dizziness, lightheadedness, especially that head rush you get from standing up suddenly from a sitting position or lying position. Some people even, it can be severe enough that they can fall, of course, which can be dangerous. It can cause chronic fatigue, and you have to take it for a lifetime, assuming that it works and you're happy with the results. The 5-alpha reductase inhibitors work differently. They work on the receptors that block the testosterone from stimulating the prostate. As I mentioned earlier, testosterone is needed for the prostate to grow and to continue to grow. It doesn't act directly on the prostate, though. It has to be converted to this other form, dihydrotestosterone. And there's an enzyme that does that conversion. Well, these medications block that enzyme, block the effect of testosterone on the prostate, and generally produce about a 20% shrinkage in the volume if taken long enough. You have to take them for a minimum of 3 to 6 months. And again, you have to be on them lifetime to maintain that benefit. The side effects from those, because they work on the hormones, are different. They can cause a decrease in the libido and the sex drive, and they can cause erectile dysfunction in some cases. Now, assuming either the medications don't work, the medications have side effects you can't tolerate, or you just don't want to take medications for the rest of your life, you might want to consider some sort of procedure or surgical intervention. Two broad categories of that. One is the non-invasive, or minimally invasive, I should say, and can't be non-invasive. The minimally invasive and non-resective forms of intervention, and then the resective ones. So the non-resective don't remove prostate tissue. Some form of energy is applied to the prostate to shrink the tissue, have those lobes shrink away from the urethra and enlarge the urethra and the midline. Those include things like Resume, which uses water vapor, hot water vapor, the Urolift, which just simply uses metal and plastic clips that squeeze the urethra, or squeeze the prostate rather, TUMT, or microwave therapy, which again is a form of heat and less used nowadays. Other things like the urethral stent, the Optilume balloon is a fairly new one that just simply dilates it. You know, again, they're minimally invasive is the advantage. They can be done with local anesthetic in the office, but the issue is that the effects are not permanent. At some point, that prostate tissue that you squeezed or shrank is going to grow back, or sort of spring back and cause further obstruction, and within a few short years, you're going to need something else done. The more permanent or more durable results are obtained from resection, actually either vaporizing, resecting, somehow removing the prostate tissue. The sort of gold standard that's been around for decades is the TURP, a sort of friendly term commonly known as the Roto-Rooter. It uses an electrical loop and energy and heat to resect little pieces of tissue physically through the scope to create a lumen. It works great, but can have side effects like loss of ejaculation is one of the most common ones. For larger prostates that you cannot resect, typically you've had to do surgery that requires removal of the prostate tissue manually, either with open surgery or more recently with robotic surgery. So that requires, it's a more major surgery, more hospitalization. And then the latest that I want to talk about later is Aquablation, which can be used for just about any prostate size. Some stats for you. 83% of men with BPH are not willing to sacrifice sexual function for that benefit of the symptom relief. This is based on a survey of 300 patients that was done globally. 3 in 4 men, about 75% of men, feel that surgery requires a trade-off, so that they're concerned about a trade-off between symptoms and side effects. So that's what holds them back. And then 1 in 2 men that had had some sort of procedure done didn't realize just how important sexual function and the ability to ejaculate was to them until afterwards, and wish they had thought about it more. And technology and the procedures depend on which ones you can use, depends on the prostate size. This is a nice visual of different fruit sizes that gives you an idea about the proportions of how big prostates can get. On the smaller end, 30 to 40 grams. So this is about twice the size of a small prostate, which again nobody has unless they're about 20 years old. You could do the minimally invasive procedures or the non-resective procedures. You could do the TURP up to about a size of 80 grams. So this is a more sort of moderate to large prostate. If you get to the really huge prostates, above 80 or 100 grams, 150 grams, you cannot do those, the non-resective procedures, and even the TURP becomes inefficient. It's manually done. It takes a long time to resect up to 80 grams, and beyond that, it's just not feasible to do it safely because of the length of time you're under anesthesia, absorption of fluids, blood loss, and just the effort that it takes. And you may need to be a stage procedure that requires multiple resections. So typically when you get to the really large sizes, as I mentioned, you would need to do the either laser enucleation, which is not done by most people. It requires a very steep learning curve and not many people do it. Or more commonly, prostatectomy. That's actually removing surgically the prostate tissue, like I said, with open surgery or with robotic surgery. Now, it would be nice if we had an option that was minimally invasive, endoscopic, and can handle any size prostate, and that's what Aquablation does. That is the efficiency of that. That is efficient, it's safe, and effective for any size prostate. Some more statistics. More than 12 million men are being actively managed for BPH in the US each year. About a third of them, 4 million or more, are unwatchful waiting. They have symptoms, they're choosing to live with them or suffer with them because they're worried about side effects. 6.7 million, or about 2/3, are on medications. The alpha blockers, 5-alpha reductase inhibitors, and they're putting up with the side effects, they're putting up with titration of the doses, switching brands to find out what works without the side effects. And about 1.1 million are just not, the medications are not working for them. Again, for one of those reasons. Ineffective, too many side effects, etc., and have chosen to go on to the next step. There are about 400,000 surgeries done for the prostate in the US each year. But that leaves about 700,000 or more of those patients that are not responding to medications, who are not having surgery because they don't want to have that big surgery. Maybe they're too ill to have that big surgery and be under a general anesthetic for a long period of time. Or maybe they're just concerned about those side effects or potential complications. So what are the advantages of Aquablation? One is safety. It is as safe or safer than the gold standard, the TURP, the TURP. It's efficient. It can handle any size prostate. And it is effective. I did that backwards, but you get the message. So it works really well from my experience with it, and from all the data out there, it produces really good results. A little bit of timeline about Procept Probiotics. That's the company that developed Aquablation. I believe it's been around for about 10 years and started developing the Aquablation a few years ago. It received FDA clearance in late 2017. And from there, because of the quality of the studies and the effectiveness, it was rapidly adopted into the guidelines of many places, including the Canadian Urological Association and in Europe in early 2018, and then by the American Urological Association in 2019. It received Medicare coverage in late 2020, which then obviously made it available widely, and then it's been very rapid adoption ever since. It is the fastest adoption of a medical robot in US history, according to this data. So how is it done? It is the only image-guided and robotically assisted procedure for prostate surgery. What happens is we would place an ultrasound probe in the rectum, kind of similar to what we do, as I mentioned earlier, to measure the prostate size. And then there's a scope to visually look at the prostate. In this image here, this is a sagittal or sideways view. The base of the prostate is here, the apex or the urethra is on this end. The dark part here is urine in the bladder. And you could see how the prostate here protrudes into the bladder. And this is all solid prostate tissue. You can't even see the urethra. It's compressed in here somewhere. This is the view of that urethra here in that middle, in between these two enlarged prostate lobes. So once we get everything set up, then I will program the robot to the different zones of the prostate. The bladder neck, where we want to protect those involuntary, the involuntary sphincter, the smooth muscle in there. I'm sorry. This extra lobe that really needs to be resected completely. The middle part of the prostate, where you want to resect nice and deep, because that is where most of the adenoma or the obstruction is. And then this Viru protection zone, we call it. The Viru is the little nubbin where the ejaculatory ducts come in at the apex of the prostate. That's the area you want to protect to preserve ejaculation. And this allows us to do that by marking where that is, using ultrasound and visual guidance. The robot knows to resect around it rather than in the midline where the ejaculatory ducts are. Once I get it all set up, I press the pedal, I'm monitoring it the whole time, it's under my control, but then the robot is doing the resection. A very small, powerful water jet comes out from the tip of the scope and starts to go back in a steady fashion, resecting exactly where I tell it to and how deep I've told it to with my program. And the result is this. This is a cross section, and you can see all the dark is now urine or water irrigation here flowing through this clear prostate. This is the top of the prostate, this is the bottom of the prostate, and this wide, nice open channel is the resected tissue. Now this is a scope view, and you can see this dark area is this nice wide urethra now, where there used to be these obstructive prostate tissue here. This can be all done, no matter what the prostate size is, in about 3 minutes. So most of the procedure under anesthesia is just the setup. The actual resection takes just a few short minutes. It's amazing. Not only have we had excellent clinical results, but there have been 3 large studies over many years that have shown that it is superior to the TURP in terms of symptom relief, especially for the really large prostates. It has lower complication rates, especially the ability to preserve ejaculation, and fewer retreatments. If you remove more prostate tissue, there's less likelihood that it's going to grow back or scar down and cause you problems that requires retreatment. It is backed by long-term clinical data. There are several studies that are quoted down here. 100% of the men that were sexually active or had good erections before the procedure maintained their ability to get an erection. It does not affect erections in any way. The nerves to the prostate are actually on the outside. We're resecting on the inside. And since this does not use any heat or lasers or any sort of energy that can be transmitted across the prostate tissue, those nerves are not affected. 90% of men had preservation of their ability to ejaculate by preserving those ejaculatory ducts. By knowing exactly where they are with the ultrasound and the scope, you can preserve that ejaculation. And 99% plus, way well above that, of men do not leak or have incontinence afterwards. If you do, with any prostate surgery, it can happen. It's really rare, and it's very, very small amounts, like coughing, sneezing, and a tiny amount. At any rate, the aquablation produces the least likelihood of that and the smallest amount. I haven't seen any in my practice. Because of all these benefits, there has been very, very rapid adoption. You can see that it was just approved by Medicare fairly recently in the grand scheme of things for any surgical procedure. It is now in more than 300 centers across the US as well as the world. Worldwide procedure growth has been very rapid. 35,000 procedures have been completed globally. More than 1,000 surgeons are doing it, including yours truly, in more than 16 countries across the world. And there have been over 150 peer-reviewed articles published in various journals. By 2027, we expect this to be the standard care for BPH. It is for me currently, for any size prostate. There are risks to any procedure, of course, and your surgeon can discuss those with you in more detail if you choose to go in that direction. And that is my time. Thank you so much for your attention, and I will field any questions now.
Thank you, Dr. Saleh. We do have some questions. The first question is, what is the recovery time after Aquablation treatment?
Yeah, so currently we keep you overnight for observation. There's always a little bit of blood loss when you have any surgical procedure, even minimally invasive ones. So you'll be kept overnight just to flush the bladder out and make sure that the bleeding is under control, which it is usually by the next morning. You go home the next morning with a catheter for a couple of days, again, because we don't want you to have to deal with those blood clots over the weekend. When the catheter comes out, and as soon as you get home, you're ambulatory and you're able to shower and eat and do most daily activities. But we ask you to avoid really heavy strenuous activity and exercise for 4 to 6 weeks. And again, that applies for any surgical procedure involving the prostate.
Okay, thank you. Our next question is, who would be a good candidate for Aquablation? So
anybody that has an enlarged prostate that's causing symptoms. Really, at the one extreme end, of course, anybody that has a complication. So the urinary retention, the hydronephrosis, the recurrent bleeding, and stones, etc., those need some sort of intervention. Anybody else, the vast majority of patients, it's up to the patient to tell me when they want something done. The medications are not working, they don't like the side effects, they don't want to be on medications the rest of their lives. And in terms of the prostate size, anatomy, anybody qualifies for aquablation. There are certain size prostates that you cannot do the minimally invasive procedures in the office for, or even the TURP. So in terms of prostate size or anatomy, there are no restrictions.
Okay, the next question we have is Aquablation ever done in an outpatient setting?
Not currently. I mean, I think just because it's a relatively new technology and we just want to make sure that we're watching everybody carefully, it could certainly be done that way. And I think there are some surgeons that have started doing that. We'll probably head in that direction. Currently, it is done in the hospital with an overnight stay.
Okay, and our last question, is there anything I can do to prevent BPH?
Unfortunately not. As I mentioned, it is really genetically determined. The prostate is going to keep growing, and the rate of growth depends on genetics. Did your father have an enlarged prostate? Did your father need prostate surgery? It's likely that you will as well. But there's nothing to really prevent it. A healthy diet, of course, a heart-healthy diet is good for your prostate. There are certain things like pumpkin seeds, flaxseed, saw palmetto, herbal supplements that may help alleviate the symptoms somewhat. But to my knowledge, none of that is going to change the trajectory of the prostate size or the prostate growth.
Okay, thank you. This does conclude our program. And thank you, Dr. Saleh, for this insightful presentation. Thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.